Hi, this is Kiffer with Week 8. Today we're going to be talking about how to review and critically assess evidence. As you recall, in previous weeks we've discussed how studies are designed, what the strengths of those studies are, what those limitations of those studies are, and how they result in data that can be used to guide decisions in public health. In slide 2, you can see that the review of the evidence and the meta-analysis kind of sit at the top of the evidentiary pyramid. And this is because reviews are meant to take all the evidence that has been produced thus far in a field and summarize it into a cohesive and actionable policy recommendation so that you can actually do something with the data that has been produced by various case control and cross-sectional cohort and randomized controlled trials, and so that you can really have a good sense of what it is that you're trying to do. On slide 3, it's important to remember that all of these kind of research study designs that we do are done in the aim of prevention, and that at various stages we can stop the development of disease by either presenting risk factors, such as in primordial prevention. We can stop those risk factors from contributing to disease, such as what we do in primary prevention. We can identify illness and therefore treat individuals who are sick using secondary prevention, or we can stop a disease from leading to death or disability by engaging in tertiary prevention. On slide 4, the first step is to identify a research question or a hypothesis. Oftentimes this is stated in the abstract of a paper. Also, it might be in the introduction section, maybe in the last paragraph usually. And identifying the research question is important because you need to understand what it is the researcher was trying to evaluate so that you know if the evidence being presented in that paper is actually relevant to your review, is relevant to the specific stage of intervention that you're looking to engage in, and is helpful to basically you as a prevention or public health officer. Now, the thing to remember is that oftentimes research questions and hypotheses are framed in such a way that they have a narrative to them, that the author has kind of their perspective or their subjective interpretation of the evidence. And so a good way to identify a study research question in absence of that is to actually go to tables, look at the analyses that were performed, and see what are the variables they actually looked at. And that can be an important first step of identifying what it is they're trying to address in their research. The second step on slide 5 is to identify the exposure and disease variables. This will help you to know who it is and what it is that the researchers were using to evaluate their work. Oftentimes this is included in the abstract, telling you exactly which variables they looked at. This will definitely be true for the outcome factor, which is almost always reported in the abstract, but you may not have that in the abstract and you might have to go into the method section. Often in the method section there will be a whole section on variables, and you can look at what are the variables they used. You can assess the quality of those variables. You can assess the variables whether or not they actually measure what the authors claim they're measuring. You can see if the scales they use are validated scales. You can see if the questions they use are kind of biased and might lead to misclassification and that sort of thing. And so evaluating the variables should be the very next step you engage in after you identify the research question. On slide 6, you can see that the next step is to identify the study design. You can remember 4 weeks ago I mentioned that the main goal was or that many of the problems with a study go back to the way the study was designed. And so identifying what is the specific study design used here can be as easy as looking in the method section, where they might identify the data as a cohort or a cross-section or a case control study or one of the other variations we talked about. They might not use these terms specifically, so you can also go to look in the limitation section, see if they acknowledge that the data is just a cross-section and doesn't provide longitudinal evidence or kind of anything like that. You can kind of scope through and identify what it is the study was trying to do. You can also look at the methods. What were the analytic methods they used? Were they calculating odds ratios, or were they calculating relative risk, or were they calculating survival rates? And so those sort of things will tell you what sort of study design they conducted. On slide 7, there's kind of an overview of the red flags that you're going to want to look out for. If it is an ecological study, you're going to want to be very clear to assess it for ecological fallacy. Cross-sectional, you're going to want to make sure that you recognize that the temporal clarity isn't good. With case control studies, you're going to want to pay special attention to recall bias. Prospective cohort, you're going to want to look for attrition information. And with randomized controlled trials, you're going to look at restriction information. Speaking of restriction information, on slide 8, I introduced the assessment of selection bias, which is the next step in evaluating criteria. To start assessment of selection bias, you're going to want to look for statements on what their inclusion and exclusion criteria were. Did they include people who maybe along a factor that was related to your outcome? Did they restrict people who maybe were less likely to have the outcome? And so you're going to want to look at the inclusion and exclusion criteria. But going beyond that, you're going to want to look at where they recruited. Was it a randomized recruitment process? Was it a chain referral? Was it something like respondent-driven sampling where they tried to correct for? And in each of those cases, you're going to have to kind of assess to what degree their methods of recruitment might have biased their selection. And a way to kind of confirm what you found is that in some cases you can imagine that you might have a priori a kind of understanding of what the population should look like, and so you can compare their actual reported results for like the percentage of people that maybe were white or had certain income ranges or were certain age groups, and match that to population level data and say, is this kind of matching what we'd expect it to be? On slide 4, there's schematics. You can see that these are unbiased case control and prospective cohort studies. Unbiased case control studies are balanced by the cases and controls in their exposure and the non-exposure. And unbiased prospective cohort studies are balanced by exposure and non-exposure, by disease and no disease. And you can see that that balanced design is indicated by those arrows there. And so it's important that you assess using kind of a 2x2 table. Now, you might not always be able to construct a 2x2 table depending on how they've reported their results or something like that. Maybe they've just reported frequencies. And so you're going to have to kind of do your best to evaluate whether or not you think this sort of balance was present in the study. In slide 10, we introduce misclassification bias, which again we've spoken about in previous lectures. In misclassification bias, you're going to want to make sure that those who were cases are actually classified in cases. This goes back to some of the things that when you're looking at the variables, were the variables valid? Were they reliable? Were they going to produce correct and expected results of the things that they're trying to represent? And for example, with recall bias, you can see at that schematic on the right that recall bias occurs when maybe a control who was exposed to a disease reports that they weren't exposed. And so that's a big problem in epidemiological research, as is really any sort of these biases. In slide 11, you can see that the assessment of confounding and effect measure modification is next. This is important because in addition to the sort of biases that can be introduced by conducting a study, you'll remember that we've discussed that there are kind of real-world phenomena that may give you results that are different from the results that you would expect if you were conducting the study correctly. And so confounding, for instance, and effect measure modification are two of those, and so you need to assess to what degree those might have been a problem. This is done by, usually you have to be a content expert. For something easy like heart disease, you might know, well, that you need age as a confounder. You need to include considerations of BMI and height and weight and diet and exercise and family history of heart disease, and make sure that they include all those potential confounders when they're evaluating their epidemic or of interest, so that you know that the results that you're looking at are actually adjusted for and accounting for these confounders or effect modifiers. In slide 12, you then have to assess the role of chance, which can be done in several ways. One way is to look at the p-values. If you have repeated analyses, you have something called family-wise error rate. And so if I test 100 different relationships, chances are that 5 of them are going to be non-significant or going to be significant just by chance. And so it's important that when you look at p-values, that if there's some marginal p-values, that you're more skeptical of them, especially if they've conducted lots of tests. Now, if they've conducted only one test and the p-value, is 0.003 or something like that, then you're fairly confident. But if they, ran 1,000 tests, then you should be a little bit more skeptical of those results, because they might be doing what we sometimes call as p-hacking, or where they're just looking for a significant result to report. Another problem is that another way that you can assess this problem with the role of chance is to look at the width of a confidence interval. If a confidence interval is really wide, there's a lot of error and variation in that data. Whereas if the confidence is really narrow and precise, then you're going to feel a little bit better. You can also look at sample sizes, and sometimes even the individual cell sample sizes. For instance, if you had a scenario where only a very small proportion of people in one group were diseased or something, it might just be that they were included there by chance. And while that's mostly going to be reflected in the p-value or odds ratio, it's still important to take note of those sort of things. This is because when we're working in primary or secondary and tertiary prevention, we want to be sure that the evidence that we're evaluating and the actions we're taking are actually going to be the actions that are going to stop the development of a disease or stop the development of a risk factor. And so in slide 8, we introduce the next step is to assess causality. Now, causality, as you can see on slide 14, is kind of more of an art than a science. Statistics is all about uncertainty more than it is about certainty. Back on slide 13, there are three different kind of ways that we kind of evaluate causality. One is through Rothman's causal pies, one is through what we call causal webs, and one is through using causal criteria. On slide 15, I introduced the first of these, which is Rothman's causal pie. In each of these circles that you see here, those are the causal causal sufficient causes that cause disease, and you can see that in 3 of them they contributed to disease. In 1 of them it did not attribute to disease. And so you can look and see what were the individual component causes, or the little slices of the pie, that were present in each case. And then you can identify, well, is a cause necessary? For instance, you can see that A was in the first 3 pies, but it wasn't in the last pie. And in fact, A caused disease in the first 3 pies, but the absence of A led to no disease. And so you might think, well, it looks like A is maybe a necessary cause, because without it, the disease doesn't arise. You also have in this example where you have A in all 3, but none of the other variables are actually repeated. And so it looks like that A alone was the only one that was necessary and the only one needed. And so it might also be a sufficient cause. So having A might be sufficient to give rise to its disease. For example, exposure to plutonium or uranium or something might be sufficient to cause cancer. Whereas in other things, it's more complicated than that. Something like HIV, simply exposure to the HIV virus isn't necessarily enough to cause disease. It's not necessarily sufficient. You would also need maybe you may also need to lack resistance to the HIV virus. As you can see on slide 16, that the lack of access to antiretroviral therapy might prevent the development of AIDS once you've been exposed to HIV. Lack of natural resistance to HIV would lead to the development of AIDS. Lack of natural viral control would lead to the development of AIDS. And in each of those cases, if you had them, if you had a natural resistance to HIV, or if you had really good viral control, what we call long-term non-progressors, or if you had access to antiretroviral therapy, then HIV would never develop into AIDS. And so kind of understanding the causal pathways and what are the necessary things to address in prevention kind of grounds us back in in that prevention framework that we introduced this section with. Now, this tells you something important, because if you look at a causal pie, you can actually see, well, what are the ways that we can intervene? It's probably unlikely that we're going to be able to give somebody, confer them natural resistance to HIV to stop exposure to HIV from really mattering, but we can definitely increase their access to antiretroviral therapy, which in turn helps them control the virus better. And so there are definitely things that we can do, and so identifying which pieces of the causal pie can improve prevention is kind of a great step and a great way to think about it, these Rothman pies. On slide 17, we introduce another way called causal webs. And causal webs kind of acknowledge the complexity of a disease. You can see that in this case, again, we're measuring or modeling kind of HIV developing into AIDS. You can see that there are lots of things that affect the relationship there. There's the access to art, were they HIV tested, and so you really can't get access to art until you've been HIV tested. But then there's also all these background factors way back there, like cultural influence and attitude and socioeconomic marginalization and HIV stigma, that act as kind of these background or distal factors that contribute to and shape the epidemic itself. And then there's also these kind of intermediate factors, what we call meso-level factors sometimes, that maybe impact and give rise to some of those factors. And so looking at these pathways, if we can delete some of those paths, then potentially you can reduce the development of AIDS. Because you can go upstream or you can go downstream, because like we introduced, there's primary, there's secondary, there's tertiary, and there's primordial prevention. And identifying where you can stop the causal mechanisms from contributing to disease is really the goal of public health. In slide 18, I introduced the first of the causal criteria that were introduced by Bradford Hill. The first of them is the strength of association. You can imagine that a small association, so like either has a low p-value or it's just like a small effect size, you can imagine that the strength of an association matters. That if it's a really strong association, then it's probably more resilient to a little bit of error, a little bit of bias in your study. But if it's just a tiny association, it's probably more likely that it arose by chance. And so that's one of the 9 criteria through which we can assess causality. In the next one, consistency, on slide 19, you can see that multiple estimates should all kind of arrive at the same conclusions, with high accuracy and high precision. But there are a variety of different results that when you're looking at a research question, maybe it is that all the studies out there are arriving to a very precise estimate, but they're not very accurate estimates. Maybe they're biased, maybe they weren't able to sample their population correctly. Maybe some underlying assumptions in that field of research are just wrong, and so that's leading everyone to bias their result away from what is the actual causal pathway. You can also imagine that the precision is low, and so studies are kind of producing results kind of all over the place. And so thinking about consistency of results is another great way, though just one of 9, to assess causality. On slide 20, the next is specificity. And here I present this in context of Koch's postulates, which are basically that specificity says that the virus or the pathogen that you're considering is associated with the illness, and that in absence of the pathogen, you do not have the illness, and when the pathogen is present, you do have the illness. And so that kind of shows that there is indeed a relationship between that thing. This was actually one of the first controversies in HIV research, of whether the HIV virus was actually the thing that caused AIDS. And so understanding that specificity is another great way to understand the causality between 2 related variables. In the next slide, on slide 21, we introduce temporality. And this one is pretty simple. This is what we've been talking about for the past 3 weeks, that mainly the relationship between cause and effect should be that cause precedes effect. And this is why we do cohort studies, is so that in randomized controlled trials, is so that we can get a sense of cause and effect. And so When you're looking at that, you're going to want to make sure, well, is this a cross-sectional study or is it a cohort study? Does the evidence really show that the cause is preceding the effect? On slide 22, the next causal criteria is biological gradient. This basically says that as the level of exposure increases, that the probability of the disease increases, and that the probability of no disease decreases. You could have many kind of different curves and many different shapes depending on this. For example, one thing that might obscure a biological gradient is the saturation effect, where, yeah, for a certain level of time, there is a linear relationship, but then all of a sudden, whatever level of disease that exposure is going to cause kind of maxes out. You can imagine that this might be with radiation exposure, that, at a certain level, enough radiation exposure is just always going to cause disease. And so it's just going to flatten out, even if you had way more than whatever that cutoff is. In the next example, you see a threshold effect, where the threshold effect is ultimately for a long time, exposure doesn't cause a disease, and then somehow you pass a safe limit, and then the disease really takes off. And so understanding a biological gradient and some of the exceptions is another way to assess causality. The next on slide 23 is biological plausibility. Biological plausibility is mainly that you just have a mechanism by which a disease can be caused. So for instance, with smoking and the gateway effect, you've probably heard of gateway drug theory. That the basic theory behind the gateway is that something about smoking or drinking as a gateway drug primes or prepares for more severe drugs such as cocaine to be used. In this case example, these researchers hypothesize that the gateway, the biological pathway by which the gateway effect works, is nicotine causes some biological primers which affect memory, and that memory primes people for addiction. As you may know, memory processes have an important role in addiction. And so having a biologically plausible mechanism is an important way to assess causality, because if it's just unplausible that something causes a disease, then you should be skeptical of those results. In a related definition, you have or related criteria, you have coherence on slide 24. Coherence is actually very similar to biological plausibility, but instead of engaging only the biological literature, you're also looking maybe at sociology or psychology, or basically just lived experience. You wouldn't think that certain things are related if they're just outside of the realm of kind of what is accepted to be possible. Now, of course, this isn't the best criteria. You don't want to eliminate results just because of your subjective bias, but assessing criteria with some kind of real-world, on-the-ground knowledge is not a bad thing to do. The next is experimental evidence on slide 25. Experiments, like we said, are the gold standard of epidemiological research. They're really what drives epidemiological and causal research. And so it's important that you have experimental evidence for causality. Now, in some cases, you're not going to have that because it's unethical to do an experiment, or you're going to have scenarios where maybe there was an error, maybe there was some bias, maybe the results weren't generalizable. And so meta-analyses and reviews really attempt to summarize multiple experimental studies to try to get a good sense of causality from the weight of the evidence. And then in slide 26, probably one of the fairly less used causal criteria is analogy. As you can see here in this example, just because vaccine A is effective at treating pathogen A, you could imagine that vaccine B would be good at treating pathogen B. This would require, of course, that the A and B have similar causal pathways, that the vaccines designed are similar and attack maybe the same mechanisms, biological mechanisms. And so this is used quite a bit. You can see that a lot of things are carried out by analogy. For example, in our research, one of the things I study is risk compensation, and it looks at when people start engaging in safer behavior, they feel a little bit more willing to take risks This was first acknowledged in the area of like car brakes and seat belts. And they noticed that when they put car brakes in and when they put seat belts in, people would drive faster and maybe more recklessly. Well, now in sexual health research, one of the things we focus on is like, what does the availability of treatment as prevention or antiretroviral drugs or pre-exposure prophylaxis, do those increase people's willingness to engage in risky sex? And so that comparison was mostly drawn out of analogy because we knew that there's this kind of mechanism of human behavior and human risk perception, and we believed that that would translate into something either whether you're driving a car or whether you're deciding whether or not to use a condom. And so that's really what analogy is about. In slide 9, we get back to kind of the back into the process of critically evaluating a review of literature. And the next step is to assess generalizability. And as you can see on slide 27, the way to assess generalizability is very similar to that of assessing selection bias. You can look at restriction criteria, you can look at the representativeness of the actual data, and you can say, well, are these results generalizable? Now, a lot of the research I do, for instance, is among gay and bisexual men, and so it's not necessarily generalizable to somebody like heterosexual men or to even sexual minority women. It may even be true that even conducting research among a specific subpopulation, that you're not generalizable to everyone in that subpopulation. For example, here, we had a restriction criteria that you resided in Metro Vancouver. And so somebody living in rural Alabama, these results might not apply to because whatever it is that we're assessing may not be kind of at the same level. And so assessing generalizability is similar to assessing selection bias, but with selection bias, you're mostly looking at whether or not that you biased your result in a way that would affect your actual point estimates, either by miscategorizing or by oversampling exposed individuals or unexposed individuals in the cases and controls. Whereas in generalizability, you're kind of making the assumption, well, assuming the data is kind of correct, who do these data actually apply to? And that's a problem with like cohort or with randomized controlled trials, because oftentimes you're restricting to a very healthy, very ideal set of people to show a good effect. And so those results become less generalizable because you're restricting out the natural variation in the population. In slide 10, we show that reporting a critical appraisal, this is going to be for your assignment. For a critical appraisal, you're going to want to go through each of those 9 previous steps. You're going to want to make sure that you've addressed the research question, that you've identified the variables, that you've identified the study design, that you've assessed selection and misclassification bias, that you've looked at confounding and effect measure modification, that you've assessed the role of chance, that you've thought about to what degree these results are generalizable, and then you're going to put that all together in a report or an assessment in which you can kind of say to what degree a specific research article met those criteria, what it contributes to the field. So this has to be more than descriptive. You're actually weighing the evidence. You're going to want to talk about, well, the confidence intervals were really wide or really kind of all over the place. So the p-values were all really close to 0.05 and they tested lots of tests. Or, they recruited at this one location where only these type of people live, and so they didn't have a representative or generalizable sample. Or, you can point out the positive things, that they used randomized sampling, and so that they're going to be immune from this. Or they used randomization in their case control study, so they're going to be immune from, randomization in their randomized controlled trial, and so they're going to be immune from like confounding, from confounding, because the confounder is going to be randomly distributed amongst these groups. And so the critical appraisal should be concise, but it should be thorough, and you should be able to weight, well, what is the actual scientific contribution of that specific paper? How does it speak to, and what should we do about it? What should be the prevention implications? And to what degree are there authors honestly reporting the limitations and strengths and impact of their study. And so that's going to be a challenge for you, but I think it's a worthwhile cause to follow these 9 steps when evaluating evidence, because when we do this, we can really be sure that the evidence that we're looking at and the evidence that's being published, and if you're peer reviewing, is actually going back to contribute to effective primordial, primary, secondary, and tertiary prevention, because it's going to identify the correct causal pathways that we can actually go and shut down to stop the development and stop the progression of disease. And so that's today's lecture. At the end of the slides here, I've got some questions, and I'll look forward to chatting with you and maybe having some further discussion and further questions on the discussion boards. Okay, have a good week.